Okay, so welcome to your initial certification process. If you were able to view the initial orientation session that I webcast, I can't express how happy our organization is that you've made it this far in your chosen career. And our responsibility is to provide an initial certification process that is conducive to your learning environment. So we're here to help you along the way. Of course, we're here to test you in a fair fashion. And I'll give you a little list of the objectives that we're looking at for today. So by the end of the presentation, you should know what the performance evaluation technique is, the rationale behind the standardized testing, the classic design of a testing day as it relates to paramedic certification, the test characteristics, and the principles for examiners and evaluators, and the principles of marking students' performance. So, performance evaluation methodology, what is it about? Of course, there's a lot of a process that goes behind an evaluation session. First order of business is that all candidates are presented with the same test. So, of course, different days are reserved for different testing scenarios, but all in all, the candidates who are with you on the day of testing are going through the same process. And again, it's seven scenarios that you'll be tested on. The marking sheet for each station is the same, and the specific skill modalities will be tested at each station will be the 7 different domains. So again, situational awareness, history taking, communication, patient assessment, resource utilization, decision making, and procedural skills. Those are the 7 domains that we're looking at evaluating each candidate on through each of the 7 scenarios. So again, evaluators will be looking specifically at those domains. What is the role of the examiner? So of course there's going to be 7 examiners. There's going to be 1 examiner at each station. And ideally the examiner will have a subset of clinical expertise to evaluate the candidate's performance. They allocate a comprehensive judgment on the candidate's performance at each station, and to remember the level of examination. So this is the level of examination is a new entry to practice. So that's what we're looking at from a examiner's role. Is this candidate safe to go out and practice? And if so, the scoring will reflect that. The examiner's role also consists of to observe the performance of the student or candidate at a particular task. So again, if your particular task is supraglottic airway insertion, they will be critiquing that particular procedural skill or task. The examiner also will score accurately to the global rating scale definition and to contribute to the good conduct of the examination. The role of the examiner is not to rewrite the station or interfere with the simulated patient's role. It's also not their role to design their own marking scheme. This has been predetermined ahead of time. It's not to teach. There's really no time for teaching or to provide feedback during the testing day. And again, each of those scenarios were designed and written months in advance of the testing day. This is just a picture from a particular one of our evaluation rooms. We have 4 evaluation rooms that look very similar to this, and some evaluation rooms look a little bit different, but the majority of them will look fairly similar. They may or may not have a bed. They could have a chair or a couch, different furniture that is meant to simulate what you're going to approach in a real life experience. Also, as potentially come across any type of evaluation room, there could be lots of light, there could be very low lighting conditions, so just be prepared for that. The scenario structure, so the call information, a short description of the call will be handed out to you just before the start of the scenario. So there is a little bit of time for you to confer with your partner and come up with a plan. Such as an example would be your vehicle is dispatched on a priority 4 response for a report of a female 77 years of age complaining of shortness of breath. The patient is diaphoretic and dizzy. Ideally, no other information regarding the call info will be provided to you by the evaluators. The evaluator might not actually be in the same room as you. So the way that the structure is created is that there should be very little interaction between the evaluator and the candidate. When you enter the scenario room, the patient can be simulated by one or more of the following. They could be a low, a medium, or a high fidelity mannequin. It could actually be a live patient, such as an adult or child actor. A specific trainer, it could be a partial mannequin, it could be a torso, or it could be a combination of both, an actor and a torso or a mannequin. PCP scenario time is 12 minutes. So again, once the clock starts, you have 12 minutes to complete the scenario. There will be a 1-minute warning signal that the scenario will end in 1 minute. ACP scenarios are conducted for 15 minutes. After the scenario, there is an 8-minute setup time. So after you're finished your scenario, that should take roughly around 12 minutes. You'll move to the next station, and that scenario will start 8 minutes after your first scenario ended. There's the odd scenario that actually goes beyond the 12 minutes, but again, the majority of them are meant to be completed within that 12-minute time frame. So this is an example of numerous volunteers. Of course, there's 2 crews present. You can see the partners are wearing the orange vests, and of course the lead attendants are in on the scenario as well. You can't see the evaluator in that slide, but the evaluator is close by. And this is another picture where you can see, in this case, you can actually see the evaluator who is wearing a yellow vest. Instead of actually using a live cardiac monitor defibrillator, we're going to be using what's known as a reality series monitor. And we're going to give you a quick demonstration of that here in about 2 minutes. And again, that monitor defibrillator is a yellow bag that's down close to the attendant. Of course, you're expected to put the leads on, or your partner is expected to put the leads on the patient, but there will actually be no electricity transmission through these reality monitors. They're for simulation purposes only. There's a little bit better picture of the reality series, or in that case, I believe it's an ALSI, and as well as with a standardized patient or a live patient. Ready for a little demo?
Yeah, let's go. We can actually tap in with the VGA if you want to unplug yours, if it doesn't cause too much
okay.
stress.
Stand by. We're just going to reconnect.
Just 2 VGA. This one. I don't know. You can still see the monitor there, correct?
All right. This is Luke Smart. Luke Smart is a full-time paramedic practice coordinator here at Sudbury, and he'll give you a little demo on the reality series monitor.
I'm just hoping everybody has the opportunity to see the iPad that is on the screen. However, you will have the ability to see it on the reality series here. So within the monitor itself, I have the ability to, with the iSimulate, it's basically two iPads connecting to each other, and all the periphery or the SAT probe, the NIBP, the N-title, as well as the ECG cables, 3-lead or 12-lead, are all Velcroed into the system. So we have the ability to really manipulate and recreate any type of vital sign that we choose. On top of that, we're able to actually change between a life pack or potentially a Zoll monitor. So I'm just going to make sure that I am capturing and you guys are able to see that. In 1 second here. There we go. All right. So again, I apologize if you're not able to see the screen of the monitor itself on that iPad. However, much like you see, I will be turning on the monitor right now and beginning the scenario, so to say. The monitor itself should react, all depending on what the learner is doing. So if you are going to turn on and connect the SAT probe and put the ECG on and then put the NIBP on, the rater as well as the facilitator here will be turning on those features as you're going ahead and doing them. There is usually no sign or nothing visible here on your monitor until you actually do the action. So I would ask you to go ahead and make sure you complete that task. You hit the NIBP and you attach the equipment so that you can get the result. Now the partner himself will have the opportunity to be familiar with this, and he'll be able to make sure that he's able to assist in that manner in applying that monitor. Now, as I had mentioned, the Zoll interface of what you can see here, we do have the ability to change between a life pack as well as a Zoll. So that's something that you might have to communicate. There could be that interaction within your first initial settings or seconds of that scenario, if it's relevant that you have a life pack or if it's relevant that you're using a Zoll monitor. Now, I just want to make note that all this equipment is definitely usable and applicable. However, there are certain features that are somewhat different than a real cardiac monitor from Zoll. So if at any point you have any issues or technical issues, I would continue on within your 12 seconds and just reach out to your partner to clarify that. Aside from that, we're able to recreate all these vital signs and give you the ECG, to give you the 12 lead, to give you the saturations, and all the NIBP and all the data that you would require. So the controller here is something won't be in the room. However, this big yellow monitor, what you can see here, will be in the room, and there will be opportunity definitely for you to crack this open and see where things are situated. Much like a real cardiac monitor, we have the side pouches. The defib pads are simply at the back, and there's no real need for you to actually go in the top part here. We won't be housing anything there, but the side pouches and the back pouch would be the primary ones. So.
Great.
I'm free to answer any questions that day if there's any pressing issues, but otherwise it's very easy to use. It will create that realism for you during that GRS scenario. So.
I believe there's other examples too on the web.
Absolutely, yeah. So if you do end up feeling the need to go take a quick look, iSimulate has many YouTube videos that are out there, and they do have the ability to, or you do have the ability to watch those videos. At that time, you can easily see how well this works. The soft keys that you would be hitting. Most people end up trying to hit the screen itself, but it's like a real monitor. You're hitting the soft keys to activate it. So, thank you.
Thanks, Luke.
All right, I'll give you back your phone.
Okay, just a few tips about running the call and the expectations from each of the candidates. Run the call as if it was a real one. Verbalize everything that's important. Don't over verbalize. Ensure to be loud and clear when talking. Some of our raters are in a different room and they're listening through a headset, and there's a microphone set up in the patient care room. So again, be clear, be concise. You don't have to over-verbalize. Vitals and relevant information will be given in real time. So again, we're not going to speed up these scenarios. They're designed to be 12 minutes in duration. So there's never a time where we're going to say, okay, now I've defibrillated for my third time. I'm going to initiate, another type of treatment, for example. So again, it's real time. When you plan to transport, make sure you verbalize that loud and clear, so the rater can note that. Show and say what is relevant to the scenario only. Just don't verbalize it. Make sure that you show the skill or show that you're assessing the patient. And again, say what is relevant to that scenario. Talk to your patient. If it's not a standardized or a real patient and it's a mannequin, talk to the mannequin like you would a normal patient. Obviously, if you're doing any type of assessment, make sure you verbalize exactly what you're doing, or any type of treatment for that matter. Same thing with communication. Ensure that the communication to your partner, to your patient, to any bystanders or any allied resources is again clear, concise. Close the loop. Make sure everybody understands your instructions if you are giving out instructions. You can delegate tasks to your partner. So you're going to have a PCP partner to utilize during your testing day. If you would like them to, say, obtain a 12-lead ECG or get you a full set of vitals, make sure you give them direction to do that. As well, if you are administering a medication and you'd like to administer another type of medication simultaneously or fairly close to the first one, you can delegate that task to your partner if it's a skill that they're certified in. Again, though, just be careful. If there's only one skill to do during the scenario, we have to evaluate you on that skill. So I would really only delegate ALS type skills if there's more than one skill to be performed. But any type of BLS tasks, again, you can assign those to your partner. They're a great resource. If anything is unclear, usually there's a volunteer within the scenario that can provide additional information. So if there's anything unclear to you about the scenario itself, generally the volunteers have been instructed what to say and what not to say during the day of the testing. Once your scenario is over, if you've made any type of notes, you scribbled on your gloves, or you got some printouts, ensure that you leave them within that room. The volunteers will replace the consumables out of your advanced life support bag or your basic life support bag, as well as we'll take care of any of the notes that are left over by you. The evaluators or the volunteers or your partner, they won't provide any feedback to you on the day of the testing. And that's very specifically designed for your evaluation day, that no feedback is to be given that day. But you will receive, of course, an official notice of success or unsuccess. So again, expectations from your partner. Your partner is supposed to be or will be a competent PCP. Again, they can take vital signs, prepare medications, ventilate. Make sure you guide them with the specific task that you want them to perform. Your PCP partner shouldn't initiate treatment without your direction, or they shouldn't suggest a treatment plan, again, without your suggestion. If you decide to initiate transport early in your scenario, your partner will leave the room until such time as you're going to ask them to stop the vehicle and assist you in the back of the ambulance. So the tool we're using, again, I mentioned earlier, is the GRS, also known as the Global Rating Scale. And it's, again, designed specifically for the assessment of paramedic clinical competence. It was developed by a paramedic who is still an active paramedic, Walter Tavares. And if you would like further information on the Global Rating Scale, Walter has articles online, so you can check those out. Again, it's designed to have 7 dimensions and 7 performance level points. It's an evidence-based tool to assess, and more importantly, it predicts clinical competence of a paramedic. It has been chosen by the Ontario-based hospital group to be used as an assessment and evaluation tool for an initial certification. So this is a provincial initiative where many base hospitals have been utilizing this tool for assessment now for some time. Here's a list of the definitions of the dimensions. So again, the first one would be unsafe. So not performed as required, performance compromised patient care, safety. Again, an unsafe would be an unsuccessful. Unsatisfactory would be the next category. Poor or weak, again, would be the third one. Marginal, so occasionally performance is to standard. Next would be competent, so often performed to standard. The 6th dimension would be highly competent, and then again, the 7th would be exceptional. Ideally, the success cut score would be a 4.1, so it's kind of in between competent and highly competent. Correction on that would be between marginal and competent. So marking and results, you as a candidate, you can't fail in a single scenario. So the way that this assessment is designed is that if you do poorly in one of your scenarios, it doesn't necessarily mean that you won't have overall success. Raters do not pass or fail you, they only document their observations. And again, every dimension is calculated horizontally over 7 different scenarios. So for instance, your history gathering will be marked over the course of your 7 scenarios. And then an average of those 7 assessments of history gathering will be calculated. And as long as your score is greater than or equal to 4.1, you'll be successful in that dimension. Exceptional performance in one dimension can't compensate for poor performance in another. So just like one poor performance in one dimension, doesn't necessarily mean you're going to be unsuccessful. The same goes for exceptional performance. Can't compensate for poor performance in a different dimension. And again, there's our 7 dimensions: situational awareness, history gathering, decision making, resource utilization, communications, procedural skills. And there is a mark for overall clinical performance. The services will be notified within 72 business hours. So again, as I mentioned earlier, success, if you achieve a minimum pass score of greater than or equal to 4.1 in each dimension across 7 scenarios, that is success. And if you're unsuccessful, it means you did not achieve the pass score in one or more of the dimensions. Not all is lost. If you are unsuccessful in your testing day, it is possible that the service that is going to hire you will send you for retesting. And again, that will be up to the service. It's just some rules and policies to note. Make sure to be on time. You will receive an email from the base hospital outlining the time that you should present yourself to the office, as well as some other guidelines on there. Ensure that you arrive in time, because the testing will start at a predetermined time. And if you're not there, you won't be able to participate, and it will affect your score if you start late. No identifiers, please. So if you're from a college, make sure that your patch is covered up if you're using a uniform from the college. You will be assigned an ID tag when you arrive to the base hospital program. Ensure that you bring your stethoscope, gloves, and gloves will be supplied. No cell phones or other electronic devices will be allowed during that day, or smartwatches. If in fact you cannot make your testing day, please call that number. That's the phone number to our main office, and let them know that you've run into an emergency and you can't make it that day. Medical directives such as books and guidelines are allowed during the scenario, so you can reference your directives. Obviously, the longer you look at your directives, you want to ensure that you have enough time to complete your scenario. And again, if you have any questions about the testing day, don't hesitate to contact me. My email address is on the screen. It's cptree@hsnsudbury.ca, and I will attempt to answer your questions in a timely fashion. It is a busy time of year for us with educational rounds and testing, so if I don't get back to you on that same day, I will get back to you. So again, I appreciate your attention to today's webcast, and I hope you found it informative. And I look forward to meeting each and every one of the candidates on the day of their testing. Thanks again.